Hello and welcome to ImpediMed Academy. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpediMed. ImpediMed Academy offers current customers educational opportunities to help you maximize your use of SOZO and impact positive outcomes for your patients. We will offer case study reviews and practical tips and tricks focused on lymphedema prevention, interpreting and implementing SOZO data, and more. All of our events are available to current customers at no charge. Next slide, please. Before we start today's case review panel, I wanted to share exciting new data supporting the use of L-Dex for lymphedema prevention. A recently published meta-analysis of 50 studies and over 67,000 patients showed that monitoring and intervention for breast cancer-related lymphedema using L-Dex results in an 81% lower rate of chronic lymphedema than circumference monitoring alone. This further validates the importance of using an objective and validated tool like SOZO with L-Dex in a cancer rehabilitation and lymphedema program. Next slide, please. Today's webinar is a SOZO case review with Maureen McBeth, physical therapist and certified lymphedema therapist from Forever Fit Physical Therapy and Wellness in Maryland. Joining Maureen is Stephanie Bowman, occupational therapist and lymphedema therapist from Oncology Rehab in Colorado. We encourage you to participate by submitting questions via the Q&A icon on your screen. We will answer as many questions as possible during the webinar. We will also follow up on any questions we are not able to address live. Thank you for joining us, Maureen and Stephanie. I will turn it over to you.
Joanne, thank you so much. I'm so excited to be here today and help everyone just get started with using more of the technology that your SOZO has to offer. And Stephanie's going to help me today. So I think we're going to try to really keep it low key, and we encourage questions. I've got the Q&A up. And first, though, we're going to actually talk about this process that I've sort of developed over many years of working with this technology. And part of it goes into explaining this technology to my patients. So I say to them, for example, it's kind of like if you've ever had an EKG. Well, this is an EKG of the water in your body. So then I get to talk to them about their lymphatic system and all their anatomy and physiology that I'm concerned about as they're going through a new cancer diagnosis. So I really talk about SOZO is sort of a treatment guide through this process. So this is what this infographic that we've created is really about, how I approach this data. And it's sort of to keep it simple. And I like to think of these 3 steps. One is forecasting, right? You see a patient come in and you're having a sense, if I look out the window and see the weather, does it look like it's cloudy or is it going to rain? And what does my app say? So I'm trying to make sure this data aligns. And then with that, I want to have a pathway or a route, so to speak, before I plan out a trip, right? You don't just say, I'm going someplace and start driving. You want to know where you're going. And I think patients want this too. You know, if I'm going to get them to come to the clinic for a pre-treatment baseline, they're going to want to understand, well, why should I go see my PT or OT? How's this going to help me? And this is part of implementing SOZO into that whole treatment guide. And the third and final thing is really making sure that you spend and plan to have enough time in your treatment session to go over the data. This is billable time. This is skilled time, because as we said, you know, remember your L-Dex, it doesn't diagnose lymphedema. It's telling you about those changes in that extracellular fluid in that limb. And we're the ones that have to put all the pieces together. So this is really exciting to be able to do with patients. And we're going to break this infographic down. But the data can't speak for itself. It's up to you to give it a voice. This was a famous economics professor, Dr. Ronald Cozy, who actually won the Nobel Prize. And I just love this quote, because this is what we are doing. Our professional experience is giving this data its voice. So with that, we have our first poll question. And it's, can you get that up there Someone's helping me here. Okay, so are you getting a pre-treatment baseline? And I mean this is before surgery, before chemotherapy. A true pre-treatment baseline. Okay, see these numbers are switching around here. So we've got somewhere in the 40 percentages of people saying yes, sometimes maybe 30%. Okay, almost half, 48% at this point are getting that true baseline. Kudos to you, because this is really important. We need to, tell a story to do something remarkable. And that story really starts with having that true pre-treatment baseline. All right, I'm going to give it anyone else out there. Okay, so here are the final results at this moment. 44% yes, and I'm going to share these results with you. So 16% no, and 41% sometimes. So I hope by the end of this, you're going to see that you're going to want to get 100% of us into that. Okay, so back to this. So when we're talking, and some of you, if you saw slides 2 years ago, this is from 2 years ago, when we're talking about adoption of new technology and clinical practice guidelines and how we get people to do this, it's with our own unique experience and the knowledge we get, but really it's about getting our patient to go along with that through the patient experience. And so SOZO is really at the heart of everything I do in my clinic. And I think Stephanie is going to tell you more about her experience with that too. So our patients make this commitment every day. And to any of the KU people that may be out there, this was when I came to see you one time, that I found this in a cancer survivors park that was in Kansas City. And I thought, this is amazing. Make a commitment to do everything you can in your power to help fight the disease. And I really feel having that SOZO data is part of what they can use this for. So here's the first part again, remember forecasting. So back in 2016, I presented some of this early data at the NLN about body comp, and I was concerned about whether or not some of my patients actually had a higher lymphedema risk, because even though their BMI was normal, their body fat was very high. So I'm using this to kind of forecast the patient that I have in front of me, not only what they just look like, but really get their numbers. And that's where body comp is so important, and to get that initial L-Dex score. We know weight gain is an incredibly critical piece of not only patient's body image, but it's a risk factor for impairments and potentially poor outcomes of treatment. So as a physical therapist or occupational therapist, being able to actually measure body composition is very important to me. And this is why, again, that is actually me on the left side. And that was one of my patients on the other side. My BMI was high, but our body fats were both 31%. We both were at the high end of normal. And this was critical to know, because she actually wanted to lose weight. But if we just let her lose weight her old fashioned way, she could do more damage by not paying attention to her skeletal muscle mass and fat mass, which we can do with SOZO. So this is also part of the planning now. I hope all of you are using the ACSM exercise guidelines for helping get your patients into more physical activity, especially during treatment. This is critical. And so this becomes part of the route that I plan out with my patient to help mitigate some of those very debilitating side effects. And I love being able to hand them this, and then they look at SOZO and they say, oh, now I see the connection that we're going to use this. So again, we have to understand what L-Dex does, and it reliably detects subclinical changes in a patient's limb because of the fluid shifts. And we can see this, as Joanne mentioned, that new meta-analysis is really great data to take back to our providers and say, we need to get this on everyone. We should be using this with all of our breast cancer patients, for example, and other patients who have lymph nodes removed, or who are going to have radiation, or who are going to have surgical resections of tissues that could be damaged. And so having this baseline, again, can set the stage for that journey that the patient is going on. So at this point, I have another question, another poll question, if we want to put that up. Let's put that next one up, and it should be here in a moment. Okay, so this is, are you getting, okay, I'm sorry, we did that one for the pre-treatment. Okay, still answer that. Are you getting pre-treatment baseline again before surgery? Okay. So I think those are about the same numbers. And I'm sorry, I may have mixed those up in terms of how many people are using. Ah, here we go. Okay, so this is the one. I'm so sorry. The body composition in progress. How many of you are actually using that body comp data with your patients? Okay, so right now, I'm going to share this in a minute, but I'm watching the numbers come in. And all right, so I'm going to end the polling here because, oh, all right, one or two more. 10 seconds left. Okay, let's share these results. So this is really the reason we're here today is obviously you love L-Dex and many of you are getting that pre-treatment baseline, but you can see the number of people who aren't quite integrating all this rich body comp data into your practice pattern. So hopefully by the end of this, you'll want to do that too. Okay, I'm going to stop those results, but that's awesome. Okay, so what do I do with my SOZO time? And this is really the third part of this little infographic. Well, again, I spend a lot of time explaining the general use of this. And this may be over and over again. Each time I do it, I try to reset the stage for them so that they understand how I'm using this as a guide. Because this picture here, I'm really trying to show this is someone with subclinical problems. And then this is what patients think on the other side. They think lymphedema has to be this big change in their arm. I want my patient to understand that my L-Dex scores can help find lymphedema before they'll ever see it. And so again, I reintroduce the anatomy and physiology at almost every treatment and really tie in the data of all the SOZO numbers that I'm getting, whether it's the skeletal muscle mass or the body fat, and their L-Dex scores, their extracellular fluid volumes if they're undergoing chemo, all those things, and I wrap that into what's happening in the moment. So now I'm going to let Stephanie talk about one of her case studies. Stephanie.
All right. Hi, everyone. Can you hear me okay? Okay, perfect. So the first case study I want to talk about today is a patient of mine that had a mastectomy, and I was able to obtain these pre-op and post-op L-Dex measures. And so a little background on her. So she was a 56-year-old female diagnosed with stage 1 left-sided DCIS ER/PR positive breast cancer. She then underwent a left-sided mastectomy on 7/1/19 with axillary lymph node dissection, and of those lymph nodes, 0 of 5 were positive. And she planned for delayed reconstruction, so her expander was placed at the time of her mastectomy. She did, however, develop a post-op complication that required her to go back into surgery because of a hematoma that developed that had to be removed. And of note of her case with Maureen talking about body composition, she did have an elevated BMI, and I'm going to go a little bit more into specifically kind of looking more what that BMI means for her. She was also right side dominant, and then some other important time frames during her treatment plan was she did develop an infection in October that required her expanders to be exchanged. And then again, another infection in November, same thing, that expander had to be exchanged. And then she started IV antibiotics for 6 weeks. And then I wasn't really able to see her during this time frame. And then eventually in December, she did have her final implant exchange. And then when she returned to our clinic in January, I was able to restart some of her care. If you could do the next slide, please. Perfect. And so here's a printout of some of her L-Dex measurements and SOZO body composition. So the big thing I want to pay attention to is looking at her tissue analysis. So we knew she had an elevated BMI, but to reaffirm that, she had her fat mass was well above the normal range. For a woman of her age and gender, we really wanted her to be at least below that 32%. So just like her BMI, she was having a higher fat mass. And same goes for her skeletal muscle mass. For a relatively healthy woman, still working, sedentary, but she had a pretty low skeletal muscle mass of 19% right there. And we would expect to see that somewhere between 25, 30. The other thing I want to look at with some of her overall SOZO measurements is her fluid distribution. And normally we want the fluid, intracellular, extracellular to have this ratio of 60 to 40. And, at this time frame, she did have a relatively good ratio right here. Next slide. And so next I want to discuss how I'm using the SOZO data captured to establish a treatment plan for this patient. So like I said, I was able to get a pre-surgical baseline assessment for her on 6/27. At this time, I was able to obtain circumferential measurements of her upper extremities, and then also an L-Dex score of 2.8 that was in the normative range. And then I was able to see her approximately 3 weeks after her surgery on 7/22. I then again measured circumferential scores for her left at-risk side, which was relatively normal. However, the interesting thing in this case was her L-Dex, not a huge significant shift, but she did start to approach on that borderline outside the normative range. So that's going to be a trigger to me. And then what I'm going to kind of talk it a little bit more further in the next couple of slides. I was able to start her treatment right after her post-op evaluation, 7/22, and then we continued and obtained 2 more L-Dex scores in August that were back into that normal range. And then, like I said, she developed multiple infections and had to go through a few surgeries and the end of the year, and that was 2019. And so she approximately had a 3-month absence from therapy. So although I wasn't able to treat her, at least I was able to speak with her on the phone a few times and really give her a good home management program to kind of manage that fluid dynamics that or accumulation that was occurring. And then I was finally able to have her come back in January and then get an L-Dex, and it was actually surprisingly in this normative range, which was really great. Next slide. Okay, and so here's just a blown up image of her L-Dex history. And I just want to spend a little time speaking to these pre-op and post-op scores. So the pre-op, we had that normal baseline pre-surgery range at 2.8, and then post-surgery that we were able to get that L-Dex again, and it's showing that there's some type of fluid shift that's happening. And more importantly, I want to talk about what's going on in between these two measurements. What is causing that fluid shift that the L-Dex is picking up on? And we know that because of her baseline measure that we know she was having surgery with the lymph node dissection. And so in the next few slides, I really want to speak about what's going on here and identifying, this with our SOZO data as an acute lymphatic injury that occurred. And then if we are able to identify these acute lymphatic injuries and gauge where this patient is in her tissue healing trajectory, that way we can implement our treatment in an appropriate time frame to really maximize, the functional recovery of her system, of her lymphatic system, and then really provide the best outcome and prevent that chronic disease progression. Next slide. And one of the benefits of obtaining these pre-op baseline measurements is for this early risk detection. So at her pre-op, I already knew she had a few risk factors right off from the bat that, we knew she had this high BMI that associated with increased risk of developing breast cancer related treatment and also a poor prognosis for the outcome with that higher BMI. At pre-op, I knew she was going to have some type of axillary lymph node dissection. I wasn't sure exactly how many lymph nodes were going to be removed. Unfortunately, only 5 of those were removed and none of them were positive, so she didn't have to have radiation. However, during her treatment, she developed multiple infections and she had to go back into surgery multiple times for these infections, which, all of these were acute lymphatic injuries to her system that could have compounded and lead to this accumulation of fluid in her compromised territory. Next slide. Perfect. And so when I mention acute injury to the lymphatics, so that's going to be any type of surgery, radiation, chemotherapy, trauma, and specifically axillary lymph node dissection that's going to start an acute inflammatory process with the phases of soft tissue healing. And, at one point, we definitely want her to go into this inflammatory stage. That's a part of the tissue's natural healing process. And then that means that the patient is automatically going to be positioned in the stage 0 or subclinical range of lymphedema. However, in her case, because she had these lymph nodes removed, her threshold for developing lymphedema is reduced. And so when I can identify these acute lymphatic injuries using the SOZO, I can put this patient and get them into referred to me in this optimal time frame at 2 to 3 weeks after this injury. And this is a really beneficial time because we have the opportunity to help these patients transition from this inflammatory stage into this more productive natural progression of proliferation stage of tissue healing. And then as clinicians, we have the benefit of mitigating the effects of lymphostasis and secondary skin disease that can contribute to clinical irreversible lymphedema. Next slide. And so to understand this shift, I really want to speak to the physiological perspective. As most of you know, lymph fluid is waste products of the body. It's made up of protein, long-chain fatty acids, bacteria, viruses, and remnants of foreign particles. And specifically, these protein and long-chain fatty acids are large undigestible proteins, macromolecules. And what will happen if the lymph system is damaged and they can't remove these large undigestible macromolecules, they're going to start building up in the tissue, leading to lymphostasis. And Dr. Stanley Roxon really describes this process very well as a complex biology that will signal humoral and growth factor mechanisms, leading to secondary skin disease with adipose deposition, increased dermal cutaneous thickening. And this process right here that leads to that secondary skin disease, this is what's going to transition a patient with a liquid form reversible stage 0-1 lymphedema to a chronic, solid, irreversible stage 2 to 3 lymphedema. And when that shift occurs, when you get into that solid phase lymphedema, it's going to result in an overall progressive reduction of the overall functionality of the entire lymphatic territory, not just in the lymph nodes, but in the initial lymphatics that are responsible for clearing out that lymphostasis. And this progression leads to this feed-forward loop of disease pathology.
Stephanie, we have the best question that just came in.
Oh, sure.
That I think is going to really, settle. So they said, wouldn't you expect some post-op swelling still at 3 weeks post-op? And the therapist was saying, I usually wait 6 weeks to remeasure L-Dex so I don't jump into unnecessary treatment when it could be just natural healing process versus lymphedema. But this is what we're talking about, right? Like, I still want the data, don't you?
I do. And I'll challenge that question because yes, there absolutely is going to be post-op swelling. But as we know now, any type of swelling is lymph swelling. And if the lymph system is functionally decreased because of that lymph node dissection, I would at least want to, if it was me in that position, I would want to know we did everything preventatively as possible to prevent that disease progression. And if we know there's already going to be a buildup in the starting of that lymphostasis development, if we can implement our treatment and use our MLD, our range of motion, our therapeutic intervention, mitigate that progression and just, eliminate any of that potential for accumulation of swelling, I would at least start, that 3 weeks, because that is the opportune time that we can help prevent that chronic inflammation from prolonging past that 3 weeks.
Yeah. And, I've spoken to you about this, and a lot of you probably listening. I get some of the micromassage techniques in play then. Things, like any of these like tactile fabrics and stuff that create, that lymphatic flow, because I'm trying not to let things settle in. So that's why I love that early time. So
Yes.
All right, awesome. Well, next slide
Good
yet?
question.
All right.
Perfect. Next slide. And so this is where the SOZO really comes into play. So we can use this as a clinical assessment tool to gauge where this patient is in their tissue healing trajectory. And that way we can position our treatment appropriately and provide the optimal amount of care to negate any of this chronic disease progression. And then we have the opportunity to mitigate the onset with this early detection combined with our skilled therapy intervention. And then the ultimate goal of our treatment is really to optimize the recovery of the lymph system following any acute lymphatic injury to avoid this lymph congestion and the overall lymph stasis. Next slide.
Sorry, my finger's slow. There you go.
Okay. And just to kind of summarize, and this kind of goes back to the point that the question brought up, the benefit to seeing these patients 2 to 3 weeks after surgery. So this is the opportune time that we have with the normal tissue healing trajectory to help support that transition from that inflammatory stage into that proliferation phase. And then the lymph system, once again, has that potential for optimal healing and regaining all strength for functional activities. Even though there's, with lymph node dissection and trauma, we still have that potential for it to regain and, through lymph angiogenesis, really promote the healing of the system. And our goal as therapists is to stop that acute inflammation process from progressing. And then we do this by implementing our treatment in the optimal window and time frame. And without this transition from this inflammatory phase to the next stage in healing of the proliferation, this transition failure will lead to uncontrolled inflammation, tissue induration, fibrosis, these secondary skin disease changes that are going to contribute to chronic lymphedema that this patient is going to have to deal with day in, day out for the remainder of their lives. And that's why I'm so adamant about really, educating my patients about the use of SOZO and then using that through that continuum of care to identify any of these acute lymphatic injuries. And that way we can mitigate with our therapy intervention, which we know is effective, to prevent this lymphostasis from occurring.
Stephanie, I think that's awesome. It makes me think about we'd never wait, too long to treat a total knee, right?
Correct. And the same thing goes, if we have a total knee, we wouldn't just leave it to its own accord to heal. Exactly. And especially with the lymphatic system, we know that we are actually removing a functional part of that system. And so it makes sense that we intervene early and restore that function in an optimal time frame.
Yeah, no, that's awesome. So, we had a couple other questions come in. One was about the weight capacity, and I'll let someone, I think it's 375. Yep, I just got confirmation, 375 standing. But I've had some patients over that, and you can test someone sitting. But if you start testing them sitting, you have to continue doing that.
And Maureen, the weight capacity seated is 750 pounds.
Oh, all right, awesome. Thanks, Christy. Christy Green's here, everyone. So this is a great segue because I'm going to start talking about one of my case studies, and someone had a question about specific goals for body comp numbers. And I'm going to go through this next slide here. And this is actually an advanced breast cancer case study. And Stephanie, stay on with me if you want, because, I think it's nice if you have anything comes up, please let me know. And so, this particular patient came in to me and she had a triple negative breast cancer, ended up being stage 4, originally treated in 2013, was restaged after recurrence. Her treatment for the recurrence was just a complete axillary node dissection. Unfortunately, that September of 2019, she had a neurological emergency and basically collapsed on her floor at home. Her legs went out from under her. And it turned out she had a big lesion on her spine where she underwent an emergency. You can see the size of this laminectomy fusion. It was huge. She has major hardware in her body. When she came in, she wasn't really thinking her lymphedema was that problematic. Her lymphedema life impact scale wasn't that bad. She had all these residual neurological impairments, a lot of functional problems, and her gait was really off. She was using a quad cane, could barely walk. Now, for me, it was really her, I thought 18.2 was pretty high for an L-Dex. what was so interesting following her, and you can see this started right before COVID hit, and she was one of the few patients I still saw through COVID as we tried to stay open. And what happened with her is she had this major disease progression during that time. And I could see it on SOZO. I mean, even in the L-Dex scores, to watch her L-Dex just skyrocket and go up to 45.7, we knew something was on. And they had to do some radiation on her at that time also to calm the tumor down. And it did. And so finally in July, you can see down there, she started some Xylota and has done really exceptionally well on that. So you can see this like downward trend of her L-Dex. She even had a normal score in November. It was so exciting. So, managing that lymphedema is just one part of this with her. So I'm going to let this data go now. And I'm going to show you, this is some of her body comp and weight data. And yes, I did set goals for this patient because she was so underweight. When she came in to see me, you can see there, she was 119 pounds, soaking wet, as they'd say. And she was really, just talking about how she could barely eat when she had been so sick. And she had an appetite now, but she was not feeling well and she didn't look well. She looked unhealthy. And so she loved having this data. And again, this was one of these patients that wanted to hop on SOZO every time she came in. She's like, can we just check? Can we just check? And sometimes I'd be like, okay, don't worry about it too much. But, we pretty much would get her on this. And this is where I was able to get her weight up just this past week. She's 134 pounds. She doesn't look sick. She says her friends look at her and say, wow, you look like you're back to normal. And of course, she still has this really significant disease. One thing I've also been able to show is that phase angle. Remember that phase angle is kind of like that cell wall health, so to speak. That's the way I describe it to my patient. And her cells are so much healthier right now. So this is really exciting trajectory to see on this patient and to see where we took her and where she is now. So on my next slide, though, if I can get my key to work, this is what's happening with skeletal muscle mass. And so, you can't get too upset when you see this dip a little. This woman has stage 4 cancer. She's under very heavy treatment burden. I'm going to see this dip, but as a percentage of her body weight, it's still really stable at 26.2%. That's still in that range, unlike Stephanie's patient, right? Where she was only 19% and didn't have a severe disease. This patient, by building up her fat mass also, she really has this cushion for the rest of her disease process that she's going to go through. She's not going to live forever. She knows that. And she really likes being able to look at her data and know that she has this cushion to get through treatment. So, with that, let's look at what she's able to do now. This little picture here down below is the little hills and embankments right out in front of my clinic. And she can actually negotiate up and down these she's now using one of those trekking poles from REI. They're the best things for your patients. They don't think it's a cane and they can fold it up and put it in their bag, but she goes hiking now and she's safe to do this. And we've actually even taught her how to fall safely if need be. She feels phenomenal. And this is because we did the therapeutic treatments, right? We did the skilled therapy that we know how to do, but we took into consideration all the data that SOZO could provide us. So I have one more mini case study before we wrap up some things, then get into some of these questions that are coming through. And this is a patient who actually came in. She had breast cancer in 2017. Doctors hadn't told her anything about lymphedema, didn't have any pre or post-op interventions. She just thought she had to live with these things. But she came in with some leg swelling. Her doctor said, well, go see this therapist. She also had major arthralgias from an aromatase inhibitor, a lot of range of motion and tissue tightness. She was still so wound tight. She had that kind of neurological tightness that people get from trauma. Hadn't released any of that. And you could, drop something, she would just jump. And putting her on SOZO, I also found out she had a high score. And so without that baseline, remember, this is the beauty of it. I could see that she was having a problem. Now, she had a slight difference. You can see there her arm volume is 139 mils. I'm not going to necessarily jump and treat that right off the bat, but her L-Dex was positive. So again, this is a patient coming in. We couldn't do a ton of treatment on her. She was still working at the time before COVID as a substitute teacher. But then as COVID progresses, she ends up not working so much as a substitute and gets diagnosed with carpal tunnel syndrome. And so in the summer, she starts to go in for treatment for that. So she's seen a different hand therapist for that. And she starts to get all upset because as the hand therapy progresses, her numbers start to go up. And then finally, as the COVID restrictions decreased, she was able to get her first carpal tunnel surgery. So I start to see things, and that's that kind of first blue arrow you see there. Okay. I know the surgeries are happening. I mean, the second surgery is that black line, and you can see that that's where she has the carpal tunnel surgery on her left hand. So I'm assuming those things are going to happen. But what I want to ask you is, you saw some other peaks there. What else do you think could be happening with this patient that I wasn't really telling her story and paying attention to? And this is going to be an important thing coming up in the future, I think, but just in your own head, I don't have a poll question for this. But remember, I knew about her surgeries. I knew about the therapy she was getting, but I'm going to tell you, here's what happened. These other arrows actually represented shingles vaccines. And I didn't know what was going on. And after she was recovering from her hand surgery and she then got a blood draw in that involved arm, I just couldn't understand what was happening. Our treatment didn't seem to be working. So I got down, said to the patient, come on, let's sit down. Tell me everything that was happened. I showed her this graph. She looked at the dates. She got her calendar out. She said, oh my gosh, I got the first part of the shingles vaccine back in July. And it's like, oh, so that's what that jump up into the red zone actually was. It probably wasn't even her therapy and the surgery on the right hand. That light blue line turned out to be the blood draw because she has a good vein on the left side and didn't really realize maybe she shouldn't use that. And the second half of the shingles vaccine, for those of you who haven't heard, it's usually a doozy. And a lot of people are really having reactions to that. And so that's what that second big dip was. Once we recognize that, you can see she drops right back into the normal zone. And I will be testing her again about 4 weeks. So I think she's on my schedule next week. And it'll be exciting to see what happens with her. So this is a great way that you can get this data and work with your patient, and it's actionable for them when they can look back and see the dates. And this is what I love about it. So Stephanie, this is what we're talking about, right? Of implementing this early.
Absolutely. And so this is going just back to reiterate, that opportune time frame, and just to really stabilize any subclinical lymphedema, the stage 1, where we have the opportunity and the leverage to actually have an impact on the lymphatic system. And so unfortunately, we cannot change the disease pathology and process of this chronic progression. However, we have the ability to leverage the data, using the SOZO, and identify where they are in that tissue healing trajectory, identify any acute lymphatic injury in order to mitigate clinical lymphedema onset. And then once again, providing the patient with the best opportunity for recovery with our skilled therapy intervention. Next slide.
Yeah, and well, just on this though, a question did come in about, do you test patients if they have drains in?
So that does happen sometimes when the drains are in. I'm going to use that as a little caveat that yes, I'll still do it. It's safe to do it on the L-Dex, but I know those measurements are probably going to be skewed. And then as soon as they're returned, eliminated, then I'll do it again. And the fact that they still have drains in, for that prolonged time, if they have them in past that 2 to 3 week time frame, it's already showing that their lymphatic system is struggling. So then I'm going to be even more mindful in understanding why are they still putting out so much fluid, and why are these not being able to remove? They're going to be at more risk for seromas, lymphoceles. So that is another reason that I really want to intervene in this time frame to make sure I can address these issues.
Yeah, and on this same thing, some of the patients who are in these big long surgeries, where they're having reconstruction right away, sometimes they've gotten tons of fluid during the surgery. So that's where I love to have some of those ECF and total body water measurements pre-treatment, like pre-surgical. so then I can kind of look and say, oh yeah, you are just full of fluid. I mean, you just have, it's not lymphedema, but your body just has all this fluid. You had anesthesia, you had, how many bags of saline do you think they ran on that patient who had a 10-hour surgery, right? So
Right.
this is where, utilizing all that body comp is really, really important. So, I'm not sure how we could also tie this in though. Although let me go to your next slide, and maybe I forget if this is the one that's going to answer that question, but, well, let's leave this here. But one of the other questions was, what type of prehab for patients who are high risk and doing chemo before surgery? So those patients getting neoadjuvant and surgery maybe 4 months out, what kind of prehab or treatment do you start to get in? And, do you do anything if they spike a high L-Dex?
Ooh, that's a good question. So absolutely, I'm a big supporter of the prehab, and at Oncology Rehab, we really implement, treatment through that continuum of care, that prehab, that rehab, and that surveillance. And then with a patient that we know they're going to have neoadjuvant cancer, we know they're having probably a more aggressive cancer. Yes, we want to implement rehab even before that that neoadjuvant chemo. And this is going to be helpful to really increase the functional tolerance of that patient. If someone's already weak and deconditioned for whatever reason, and then they go into surgery, it's, they're going to have a poor prognosis. So if we have a treadmill test that we use here that's specific for cancer patients, and we kind of give them an exercise guideline and parameters based on what chemos they're going to have. And really just the main goal is to increase their functional tolerance.
Yeah. Yeah. I mean, I think it's really important to talk about how, that ACSM cancer, rehab, the exercise guidelines, I mean, integrating them into the rehab protocol, because there's no reason these patients shouldn't be exercising. And we know that's going to help them, clear some of those fluids, and, because they're all getting a lot of fluids when they're running these chemos. They're getting, fluids the day after. And so, I like to still see them. And, I do kind of, if I see someone pop a high L-Dex score during then, I do some of my early intervention treatments that are usually the micromassage garments again, something really easy to use. And depending on what chemas they're getting, and if it's got a high profile for neuropathy, I'm even getting some compression on their hands, especially in their feet, with something like one of those chipped foam booties or some of those chipped foam or an easy garment to wear, just so they don't get, as many issues with the neuropathy. So I just love this slide though, about that optimum treatment window. And I really think that when, one of the other questions is kind of like, how do you, share SOZO data with your doctors? Like what, do you call them? Cause I do. I sometimes call them.
Absolutely. So unfortunately, especially with my case study, so when she had all these infections and surgeries, so we were really trying to give her that kind of 2 to 3 week time frame. However, to get her back in, but then however, another thing just kept on happening and kept on happening, where it ended up being almost 3 months that I wasn't able to see her. But this is really what I will, I called the physician and be like, hey, can we get her in? But it was just, timing wise, it just didn't work. And then at the new year, she had met, she had a whole new deductible and out of pocket, which was just like a bummer because we couldn't get her in more regularly. Thankfully, she, through me talking with her, she was able to kind of really handle those fluid shifts. But yeah, if I'm on tumor boards and speaking with physicians, and I really want to advocate for that early referral, and just this is the perfect slide that I will show them, and then showing them, if we stay below this transport capacity and don't overwhelm the system that's already going to be assaulted by so much more subsequent treatments, that this is going to really help prevent any type of lymphedema.
Yeah. And so, I'm curious with this lady, for example, because we had another good question. Again, I want to go back to that question about making specific goals for body comp numbers. And, I'm definitely telling my patients, like, look, I want to get your skeletal muscle mass above 25%. And in those rare cases, like with the advanced cancer, sometimes it's going to be a little skewed because they're actually so thin that their skeletal muscle mass looks really high. And maybe that could be a topic for another webinar in the future. But, I think it's really important to say to them, like, I do want you to try to, reduce your body fat, and the exercise is going to be the key. We've got to get weights in their hands, right? We can pull in all the rich resources we have in the data to show that exercise is safe. Weights are safe. I've even seen a couple studies recently about like high intensity treatment being safe. I think that's probably like Dr. Kristen Campbell or one of those, exercise folks out there that are just putting out phenomenal work. So, I guess with that, if you have any other thoughts about, go ahead.
Yeah, I was just going to mention, this patient specifically. So we know she had an estrogen positive cancer. And so, her plan, she was going to start her aromatase inhibitor. And then we know as a side effect that that's going to decrease her bone density. And she already has, really low muscle mass. So I extensively kind of discussed this with her and got her on, walking and exercise or resistance training program to really mitigate the effects that this, additional kind of treatment was going to cause. And, giving her the education of like, this is another reason, yes, your overall health, but, this is going to be a protective factor when you start this new med.
Yeah. Yeah. And so, one more question I think I want to kind of work with you is, do you have flow chart for how often to measure L-Dex and when to refer for therapy? And, routine versus high risk, the change, how much of the change in L-Dex? And yes, the manufacturer actually has all of that. All their literature about like test, trigger, treat actually has those. And Stephanie, I don't know, do you guys do anything different in your clinic? You guys are so far advanced. You're probably one of the most, you are the most advanced oncologic rehab place, I think, on the planet. But, how do you start kind of a typical low risk patient with strengthening, like she's asking about, like Dr. Katie Schmidt's Strength After Cancer, the Strength After ABC, the cancer program. If you want to speak a little bit.
Yeah, I can speak to that. We have a really, like you said, a comprehensive program. And so, what we'll do here is really employ that multidisciplinary referral. And so, if I'm focusing on maybe more of her posture, her breathing, her lymphatics, I'm going to refer her to maybe a physical therapist to start the program. And like I said, we have a very well-established program that we're associated with UNC, the University of Northern Colorado, and they have a specific treadmill test for cancer populations. And what they do is we go through where this patient is in her cancer treatment, whether this is a prehab treatment, actively going through chemo, and then almost like cardiac rehab, we have phases of how we progress this patient with their monitoring their heart rate, their oxygen, and their overall just body. And so that is really, I refer to that. I don't specifically do the treadmill test, but that's what we'll do. And if you are interested in that, we have a course that kind of really speaks to that. But really listening to the patient and what are their goals, I think is the most paramount thing. And then we can give them the confidence and just the empowerment to, get out there safely. Colorado's so active. They want to, people are, when can I run? When can I do this? And we need to tell them how to do this in a safe way.
Yeah. Yeah, and I think that's often how I guide my patients too, is really, that first meeting so important to, I just ask them, almost conversationally, like, what do you like to do? What makes you tick? Tell me more about, what you did before this diagnosis, and, what do you think you want to do in the future? And so I think it's so critical to pull that in. And, we do have an interesting question about the CPT code, the 93072. And Stephanie, stay on, but I want to bring Christy Green in real quick to speak to that. Christy.
Hi, Maureen.
Hey.
There is the 93702 is not time-based. So there's no time limitations on the code.
And that needs a mid-level provider above to bill. Is that correct?
It doesn't. You can just use the hospital or physician NPI number to bill. And anybody can do the SOZO measurement. There's no limitation on who can do the measurement.
Great. Oh, okay. So we had another question. Someone saw milliliters used on one of the slides before, and that's actually us physically using a parameter or a tape measure, converting it to volume. So the L-Dex doesn't actually give you a milliliter score on our outputs. So those outputs were actually our measurements with a tape measure. And so, you know, I'll be honest with you, and Stephanie, you can talk about this too. I still take volume measurements with all my patients. I do both. You know, I tell people that the mLs, you know, the volume, that's the size of the container. I want to know what's in the container. And that's what the SOZO outputs tell me, right?
Yeah, absolutely. Same thing. It's better to have more data, and you know, if someone is, you know, actively losing weight too, you know, that's another reason I want to kind of just do that volume measurement as well.
Yeah. Oh, okay. I did actually get a little clarification though on SOZO tissue fluid analysis when there's mills and things like that on tissue. Yeah, everything's measured in liters. So we look at everything in terms of like total body water is so many liters in the body. And there is a database that kind of tells you what norms should be for most patients, and their age and gender specific. So someone, you know, a 50-year-old male should have this much total body water on average. That's that NHANES data set. And I think any one of your ImpediMed folks should be able to get that to you. Christy, that's correct. So can you talk more about why we use mils and liters and stuff?
As opposed to another unit of
I mean, well, because on the device you could, I mean, versus like pints, and because I remember the old device, my legacy device, I think you could set if you used English or metric.
and you can on this one as well. So whether you want to see pounds or kilograms, centimeters, or feet and inches, and then liters or pints. So it's just depending on what outputs you would like to see the results in.
Okay, great. So I want to wrap up a little, and then please, if you have some questions, send them in right now. But, you know, I wanted to have this kind of be our last slide that I'm going to show you, and you guys can stay on. You know, we're going to make this little infographic available to you, hopefully, and I would like to put it out there if anyone has anything to add into that, because I also show this to my patients. Like, this is who helped me devise this, because I wanted something simple that could, you know, really help them through. And so this woman you're seeing here is really one of my inspirations. And this picture was taken actually out in Santa Monica at one of the Learn walks. I think Dennis Schott from ImpediMed was there, and probably a couple other folks. And she's a 3-time cancer survivor now. I first met her after breast cancer, and she was part of a database I collected data on when I actually had to have an IRB and use the research device, the SFB7, to get my body comp outputs and be able to look at impedance ratios to screen for lymphedema. And it was great to have historical data on her, because last year she was diagnosed with uterine cancer. And so we were able to get her on SOZO. We caught it really early. And I've got to be honest with you, she called me first. She called me before she called her doctor, said, I think something's wrong. What should I do? And these are the relationships. And I know, Stephanie, we've spoken about this, that our patients develop with us. And so I just talked to her today because right now she's really going through the fight of her life. She was diagnosed earlier this summer with a primary peritoneal carcinomatosis that is totally unrelated to any of the other cancers. She is just unfortunate. She's developed 3 totally separate cancers. This is not a recurrence. But we have this great data on her, this rich data that her doctors love, because she already had a blood clot in the one leg. And so we had data on her limbs. I was able to go back and say, yeah, you know, her legs were totally normal before this. And now we can look back at this. So we're still screening her for lymphedema because she's getting some really hardcore chemos now. So, you know, this is why we do this. And this is why I'm here today, to help all of you learn a little bit more about this. You know, we saw that number that most of you aren't using the body comp outputs. And I'm telling you right here, please start to use them. They're really critical for our patients. And we did have a question, you know, whether we'd have more questions, and absolutely, you know, I'm available to anyone. We can get our emails out there. Stephanie, I'm not sure about you, but You know, the hope is with the ImpediMed Academy that we're going to have future events like this to really get into more granular, hate to overuse that word, but that's really what we've got to do. We've got to get down and get into this data and not be afraid of it, because it's really rich data for our patients. And again, to help us, you know, forecast that route and put the time into our patients' lives by having this rich data. And so my lady here today, she's a scientist, by the way, a big time scientist, physicist. And she said, please, please use the data. It's really important to us as patients. We want to see it. And, you know, we deserve to know about it and know that we can make actionable changes with it. So, you know, Stephanie, any final thoughts? Christy, any final thoughts? You know, if not, I just really, well, come on, I know you'll have something to say, Stephanie.
I don't know. I think,
Really?
like we finished with this and just how our patients, this is really benefiting them. This is why we're in this profession, is to, help them. And if we have the technology to give them a better functional outcome, of course I'm going to use it.
Yeah, yeah. And, you know, hey, at the last minute here, a great question. What do you do with a negative L-Dex number? So Christy, I'm going to let you answer this. So, and what if a patient gets more negative?
So, and if it's their first measurement and a negative L-Dex, doesn't mean anything, right? That normal range from -10 to +10. So we're just looking to make sure the patient falls within that. The patient's moving from a high, moving negative, it means one of two things. They're either losing fluid in that at-risk limb. So maybe you're treating that patient and you're moving some of that fluid off, or they could be gaining some fluid in that normal limb. So we're always comparing two limbs to one another. So great question. A lot of people struggle with that negative. So doesn't mean as much as people think.
Well, that's awesome answer. And if there aren't any other questions, I don't see any other in the Q&A right now. But I'd really like to thank Stephanie. It's always so much fun working with you. Christy, your support over all these years. You've just been a champion of this in the industry, and for all the patients out there, I can't thank you enough. And I just want to thank ImpediMed, because I really cannot work as a lymphedema therapist or cancer rehab specialist without this kind of data. And I hope everyone starts to feel that way too. And with that, I'd just like to say, everyone, please stay safe out there. We're going to get through this, and I look forward to seeing you at another webinar in the future. Thanks so much.
Submitting cases. If you have any interesting cases,
yeah.
Submit them so that we can do more of these and present some more interesting cases.
Great. All right. Well, thank you everyone so much. Good night.
Thank you.
Bye-bye.